first one, make it second one, and make it third one.
Middle finger over above and below the rib. Okay, then the trigger point will be in the between. Then slide the muscle up or down over any of the ribs, so that what will happen, your both the finger will be in the intercostal space, and in between there will be rib and the trigger point. Okay, in the muscle. So insert it laterally, so that if you are going deeper also, what will happen, you will touch the rib, so no harm. Needle size 25. Clear?
Adductor muscles.
Red color marker. So basically needle size as well. Okay, needle direction will be posterior medial. Posterior is this is sartorius. Okay, so basically what will happen, the femoral triangle is what? Can anyone tell me the landmark for the femoral triangle? So it's like, see, it is, okay, this one, okay, little bit up it will be, okay.
What
so
are
basically,
the markings?
see, it will be adductor magnus, okay, sartorius, okay, this side, and then growing line. Okay. So basically you can see that this is what the femoral triangle is.
Correct.
Right. This is what the femoral triangle is. Okay. So we are not going in the femoral triangle. This side we have got the adductor canals. Okay. So we are not going that side as well. Okay. This side. Okay. This side, what will the direction left is, like, the best way is to go this way. Okay. We are not coming this way because we have got again the femoral triangle in this area. So the best way, muscle elongation is this way, so best way to go posterior and medial.
Towards the groin.
Yeah. So you can get so many trigger point. Okay, I'm not marking more. Okay, you will get so many other as well.
Posterior medially.
Clear? So if you just do it little bit above also, you are doing for the pectineus as well. Okay. So if our coastal muscles, you try to palpate the both the rib. Okay. So first palpate like this. So I'm just training it. Okay. Palpate both the rib. Then in between we'll having the intercostal muscle. So once you have palpated it, what you will do, you will try to either pull the muscle up over the rib or down over the rib, so that your both the finger will come in the gap that is intercostal space, right? Got my point? Okay. So first what you do, just I'm taking like first palpate, see this one. Okay. So what I will do, I will just palpate the rib above to that and below to that. Okay. So this is what and this is what. Okay. And this is the trigger point. Now what I will do, I will slide the muscle belly over the rib. So I'm just sliding up. Okay. So now this, see, it has come over the ribs. Okay. So rib is over between my two finger. Okay. My finger are in the intercostal space. Now what you do, you take 25 mm needle. Okay. Direction will be away from the chest wall, so that if you are going deeper also, what will happen, you will hit the rib. Okay. So away from the chest wall, that is okay. Okay. Till the time you haven't insert the needle, don't leave the muscle. Okay. Once you have inserted it, you can leave, no problem. Okay. Any doubt in this? So what vessels will also get covered in this way. Okay, inner thigh. Yep. So over this in, just use 13 mm. little bit you can put it over the inferior direction. Painful? Like this you can put 4 5. Little bit inferior. Okay. More of this. So this is what the property is. Okay. If you want better, give me the sanitizer. Basically you can just put 13 in the web space. Okay, this web space is there, na? In that you can just put 13 I will just show you one. Okay, so just okay, 13
No, right now. Back is spinning more than this. I mean,
sitting and seeing, you know.
Hamstrings.
Yeah, so this one is done.
This is superiorly
Yeah, towards the finger.
towards the toes.
Yeah. Okay, so you can put in this gap. Okay.
Yeah.
Aspect of condyle of the femur and from the head of the fibula. Okay, get inserted into the posterior medial surface of the tibia. Okay, so basically it is like, which muscle is this?
Corrugator.
This is corrugator.
No,
Procerus.
procerus.
So procerus. Okay, just try to palpate. Basically the pain will be concentrated around this area. Procerus. Okay, this corrugator supercilii.
Yeah.
Okay, blurring of the vision, then heaviness in the eyes and head. Okay, frontal headache in that case. Okay, so this will be, see this one, frontalis, frontal headache, pain will be all over this area. Okay, so this one, then this one is orbicularis oculi. Okay, so again, yeah, this one, if you try to palpate, see, it will be painful.
Yeah.
Right, after that masseter, jaw locking and all. Okay, so see this one, vaccinator.
Angle of the mandible.
Just try to palpate on yourself this here. It will be painful. Okay, see this one.
Yeah.
This is orbicularis oris. Okay, so over here and mentalis. Okay, other than the masseter and vaccinator, we will use 13 for all. Masseter and vaccinator 25 rest 13 Okay, close your eyes. Okay, so I'm using 13 Okay, direction for the process will be downward towards the nose. Okay, so do that. Okay. For the corrugator supercilii, towards the midline of the headache. Okay. So in that case, cervicogenic headache, you can treat frontalis, corrugator supercilii, okay, and procerus, both the side, okay.
Cervicogenic
Yeah.
headaches.
So then, in case of, like, you can say that if someone has got the pain, like usually in this area, that
Sinus
is
pain?
yeah, sinus pain, and then even sometimes temporal pain, you can say
Yes.
that. Okay, that is especially in case of migraine. Okay, migraine also, this will be like eyes will be very like painful,
yes,
and this
yes,
area
yes.
in this area. Okay, so that is, I will show you the, like, to like just bang this. Okay, so you get better.
Yeah.
Okay,
So it's temporal
Temporal, yeah.
temporal pain.
okay. So what you will do, basically you will get 3-4 trigger points. Just put the finger just like this, just like this. Okay,
Okay.
this is what we have got. Look over here, see, this is what we have got, this temporal mode.
Correct.
Okay, so you can get, see this, okay, 1 hour it will be somewhere, see this one, you can get 3-4, see, okay, 13 mm, again can I get some 13? Direction of the needle will be towards the ear. Direction of the needle will be towards the ear. So it's like basically what you do. Even in the facial pulses and all, you can treat all the facial muscles, okay, with the stimulation, yeah. Yeah. This is also towards the ear.
Towards the
Metatarsal. Okay. So basically it is like this. Okay, it goes in this way. So you can have it. Okay. So it's like, okay. This is what we have got, tibialis anterior. Okay. One trigger point. Yeah. This is, but it's not active, but yeah. Okay. Then for the tibialis posterior, basically the pain referral pattern for the tibialis anterior will be, you can see over here, from here to the great toe. Okay. The second is tibialis posterior. Basically the tibialis posterior is the posterior compartment muscles, okay, but it is little bit difficult to approach from the posterior compartment because we have got all the sensory structure passing from the central line. Okay, that's the reason we are not approaching from the posterior side. What you can do, you can approach it from the anterior side. Okay, so anterior side, how you can approach it, like you will find the gap between the tibia and fibula, and from that gap you can use the larger needle and you can cross the interosseous membrane and you can reach the posterior. So approx the maximum gap, you can see that it will be over here. So that will be the approx tibialis posterior. Now, okay, so this is what pain referral pattern, back of the leg till the all foot. Okay, sole of the foot. Then we have got, okay, extensor digitorum longus. Okay, so extensor digitorum longus, basically you can see over here. Okay, it will be somewhere here, and pain referral pattern will be again in the, this area will be more concentrated. Okay, like this. Extensor digitorum longus. Okay, and then extensor hallucis longus, again it will be in lower 1/3. So just palpate it over this area in between this. Okay, then extensor hallucis longus. Yeah. Okay, for tibialis anterior, extensor retrorum longus and extensor hallucis longus. Okay, for all these you can use 25 mm. For tibialis posterior you can use 40 mm. Okay, so can I get some 25 mm needle? Direction perpendicular.
This is 25.
Yeah. Okay, so then for the tibialis posterior in the gap, okay, again perpendicular. Yeah, I can raise the interosseous membrane. Yeah, it was painful, right?
It's slightly.
Slide over the interosseous membrane, it will be little bit painful, so just try to cross that area. Okay, then again perpendicular. Okay, then this would be in the functional position, that means like 5 to 10 degree of the flexion. Okay, so I am going to demonstrate the conventional type of technique. So anchor minimum 4 to 5 finger above. Yep, patella. Then again below the 4 finger down. Down, no problem, any side. Okay. Okay. The same pattern you will do from the down as well. Okay. If you want to do type of taping to this J, so J we always start from the same side of the injury, mainly in order to support the midfoot. Okay, so what we'll do, we'll start from the same side of the injury. Okay, come it like this and okay, and then so basically what does J do? It basically stabilize the midfoot. It basically stabilize the midfoot. Okay, the foot will go in the plantar flex and inversion. When it is medial, the foot will go for the eversion and dorsiflexion. So always in case of that, okay, what we have to do, we have to avoid the opposite foot, like opposite movement. Okay, so if the foot has gone to the plantar flex and inversion, what we'll do, we have to avoid this movement. So we have to always keep the foot in the opposite direction, that is dorsiflexion and eversion. So then only this soft tissue will be approximated. Okay, like I said, we will always start the taping with the anchor and always finish the taping with the locking strap. Okay, so we'll show you what is anchor. So what we'll do, I will just show one technique with this. Okay, lock it over here as well. This is for AC joint. Okay, just have a look. Everyone, can you see the sole of her foot? Yes. Okay, so first anchor will be low dye taping. Okay, so first anchor will be from the metatarsal head
Have to pull it closer. Pressure should be applied like
no, normally
anchor.
this is anchor, right? Now another anchor around the foot. You can apply either from medial to lateral or lateral to medial, anything, no problem. Just the anchor. Okay, so okay, so these are the anchors. Now what you will do, you can apply from medial to lateral also, but it is little bit difficult. You have to apply the force, so better to apply from lateral to medial side. Okay, so okay, so that automatically, see what will happen, the force will be generated medial across the medial arch.
This is also anchor.
Hmm?
This is taping.
Taping. Okay, overlapping 50% of the first strip. So can you just see that the arch has increased, right? Okay, after that what you will do, you will lock it.
What's your recommendation? How long we should keep rigid taping on?
In winter it's 3 to 4 days,
4 days.
in summer 2 to 3 days. Okay, we are going to start the demonstration for the lateral ankle sprain U strip, okay, or U strap. So I am using this under wrap. What you have to do, at least minimum 4 finger up you will start. So just measure this.
Finger from the medial.
Yeah. Okay, so this is, we call it as a tissue or paper under wrap. Okay, now nothing, just okay. Now as the name itself it says that U means just U symbol. So we'll measure, this is what U is, right? This is U, right? So we'll measure and cut the tape. So no force, nothing is required. Okay, just
So now I'm doing this, the foot should be neutral, sir. Or
just normal, neutral.
normal.
Okay. So now either the patella will be tracked medial or lateral. Okay. So only the pattern difference. Pattern will same. The difference in the side from where you are starting. Okay. So just I am doing for the lateral tracking. Okay. Lateral tracking. So whenever there will be lateral tracking, what will happen? There will be rubbing pain over the lateral side. Okay. So nothing, it's very simple. What we have to do, you have to just lift up the patella from lateral side and press the medial one. So when you are lifting it up and pressing it this side, what will happen? This side it will lift. Okay, so it's very simple. This technique was developed by Dr. J. McConnell. Okay, and that's the reason we call it as a McConnell taping. So lift it up and press it this side. Okay, lift it up and press it down. Lift it up and press it down. So, okay, so this is what, very simple. Okay. Okay, so we start from the opposite side of the injury. So if we are doing for the lateral ankle sprain, we will start from the medial side. Okay, so start from the medial side, from the ankle. Take a rod, just look over here, take a rod just above the malleolus, then take a rod over the heel, so that heel will be locked. Okay, and then what you will do from here, again same force you will generate the dorsiflexion and eversion and go straight up. Okay, so now what you will see, can you see that okay, your heels are locked completely? Can you feel the difference? Okay, yes. So we have started from here, you can see. Okay, then take a round, came up like this. Okay, then take a round, then straight up. Okay, so can you just see that this is what we have got, the V, this V, right? Okay, so that's the reason we call it as a V. And at last, finally, once you have done all types of taping, if you want to reinforce it with another strap, and later on this is what we have got, the locking strip. So one lock over here, then another lock you will do over the malleolus. Okay, sometimes what happens when you are applying the tape, that time you don't came to know that you have applied much more force, and you can see that bluish discoloration. So in that case, you don't have to remove the complete tape. What you do, you can just release the pressure. So just take, see, suppose, can you just see that it is more pressure over here? So what we'll do, nothing, this has got the rounded tip, so easily you can insert inside, so there will be no injury. If you are using the normal scissor, it is what you will do over the patellar tendon. Okay. What you will do, just tear it off. Okay, hold it. This side. This side, this side.
This.
Yeah. One. Make the. What do you call this? As a hair
Plates.
braid or something? What do you call?
Plates.
Plate. Hair plate. Braid. Okay, we call it as a choti. Okay.
So they have to learn.
Okay, so after that what you will do, you will press it over the tendon so that it will not let the tendon to slide much. Okay, with this tendon. Okay, and then just dive. One anchor mid of the calf. Okay, another anchor at the metatarsal head. Okay, so one anchor, second anchor. Now we will start with the taping. You will start from the metatarsal head.
Okay.
On the center. Okay, the foot should be in maximum plantar flex. Okay, then again next strap overlapping 100% of the first one. Take a little bit small off, then tear it off from between. Okay, then if it lock the malleolus above the from the above the malleolus, you are locking it. See. Okay. Then what you can do, you can just lock it. Lock it here over here. If you can interlock over the midfoot as well to give maximum support. Okay, lock it over here. When treatment, if you are treating the patient, what you have to do, you have to give 2-3 strap, okay, so that maximum support you will get, and then lock it over here as well. So see now, thumb will be outward. In that case, what you will do, one anchor, okay, so another anchor, okay. Now Okay, after that what you will do, you will keep the thumb medial, press it over here, okay, and then so if you want to, you can reinforce it. Can you see the gap now? Okay, you can put another strap and then lock it at the both the places. Okay.